Hi, this is Piyush Bhargava and you are watching the FDG PET-CT teaching file. Let's start with reviewing the clinical imaging protocol. The whole body FDG PET-CT scans are typically performed to evaluate patients for hypermetabolic tumors. We inject them with 10 millicuries of F18 FDG IV, wait for about 60 minutes and acquire whole body images typically from base of skull to mid thighs in a 3D mode on a PET-CT scanner. Iterative reconstruction algorithms are used to reprocess the images, and CT data is used for attenuation correction. CT is typically acquired as a low dose CT with no IV or oral contrast and is used for attenuation correction and anatomical localization. Some centers for certain cancers use contrast enhanced CT as well. F18 is a positron emitter. The positron, after being emitted, travels about 3 to 4 millimeters in the tissues and then undergoes an annihilation reaction with an electron, as a result of which two 511 keV photons are produced and emitted 180 degrees apart. When these photons are detected by detectors that are 180 degrees apart inside the scanner within a very narrow time window of 9 to 12 nanoseconds, they are recorded as a single event, and such events are collected over a period of 3 to 5 minutes per bed position to create an image. And for a typical patient, we need 5 to 7 bed positions to acquire the entire scan from base of skull to mid thighs. The mechanism of uptake is active transport of F18 FDG into the cells by glucose transporter proteins. Inside the cell, it's phosphorylated to FDG6 phosphate, and this gets stuck inside the cell because it cannot be metabolized any further. Cancer cells have upregulation of glucose transporter proteins and also the enzymes that convert FDG to FDG6 phosphate, because of which increased amount of F18 FDG6 phosphate gets accumulated inside the cancer cells, and that's how we are able to detect them on imaging. Physiologic distribution is such that we see intense activity in the brain. There is excretion of the tracer from the kidneys into the urinary bladder. There is variable amount of myocardial activity, and there is typically mild soft tissue activity. The liver uptake is typically uniform, slightly more intense than the soft tissues, and it is normally more intense than mild splenic activity. The critical organ is the urinary bladder. Let's review whole body MIP image from a normal FDG PET study. This image shows physiologic distribution of F18 FDG with intense activity in the brain. We see extraocular muscles in a symmetric fashion just inferior to the brain activity. Then we see some mild symmetric tonsillar activity. Below that, we see vocal cord activity, mild myocardial uptake, uniform uptake in the liver, slightly more intense than the spleen, excretion from the kidneys into the urinary bladder. Some faint blood pool activity and bone marrow activity is also seen. Case number 2 shows a patient with a hypermetabolic left upper lobe lung nodule. Evaluation of lung nodules was the first approved indication for doing whole body scans with F18 FDG. We want to see focal hypermetabolism. Visually, the activity should be more intense than mediastinal blood pool activity, and SUV should be more than 2.5. There are several variables that go into creating the SUV number, so it's a good idea to look at the liver SUV. Typically, the average liver SUV is around 2.0 to 2.5, and when we measure a lesional activity and lesion looks hypermetabolic but the SUV is 1 or 1.5, it's a good idea to take a look at the liver and see if the liver activity is artifactually low. Now, this is a hypermetabolic lung nodule consistent with lung malignancy with no evidence of metastatic disease, making it resectable. Here is the lung nodule seen on the fused PET-CT image. Next case is another patient with hypermetabolic lung nodule, this time in the right lung. There is a small focus of faint activity in the left side of the chest, and a finding like this needs to be further evaluated by bronchoscopic biopsy to rule out metastatic disease before this patient is deemed resectable. So here is the hypermetabolic right lung nodule, and here is that another nodule in the left lung which shows mild focal FDG uptake. patient with lung cancer, case number 4. Here we see primary in the left upper lobe. There is a large focus of intense hypermetabolism, and there are 2 other foci on the right side of the chest. Always when you are reading a PET scan of any kind, start with looking at the rotating image. Especially with FDG, it gives a good idea of whole body relative metabolism. So we see normal tissues and we see abnormal tissues, and we get a sense of how much hypermetabolic those lesions are. So here is the primary lung cancer in the left upper lobe showing intense hypermetabolism, and here is the foci in the chest on the other side, which corresponds to a lytic bone metastases in the rib, making it a unresectable stage 4 lung cancer. This patient was treated with chemoradiation. These are some follow-up images. On the whole body image, we now see multiple more foci of hypermetabolism when compared to the prior study. Now they have developed liver metastases. They also have hypermetabolic bone metastases. And we see a focus in the left adrenal consistent with metastatic disease as well. So this patient presented with progressive disease. Case number 5, another patient with lung cancer. We see a focus of hypermetabolism in the left lung. And we see another focus here in the pelvis. The focus in the pelvis corresponds to the right psoas muscle, and on this non-contrast enhanced low dose CT we don't see any morphological changes, but with this focal intense hypermetabolism we want to raise the suspicion of muscle metastases, and this patient underwent FNA which showed metastatic disease to the right psoas muscle, making this cancer stage 4 and unresectable. Case number 6, another patient with history of lung cancer. Here we see a large focus in the right lower lung zone, and we see multiple scattered foci around the right lung or in the right chest in a pleural distribution. Here is the hypermetabolic mass replacing the right lung. There is some fluid around it, some effusion, which is not hypermetabolic, and we see scattered foci of uptake involving the right pleura, consistent with metastatic disease. There are also foci in the pelvis. These foci, the one in the abdomen corresponds to a lymph node here in the upper abdomen, and they also have evidence of bone metastases. Another focus in the right ischium. Case number 7, another patient with history of lung cancer, again stage 4 with evidence of metastatic disease. The primary is in the right upper lobe, which is seen here. There is an adjacent focus of hypermetabolism. There is a focus here in the left proximal humerus, and there is a focus here in the pelvis. So here's the appearance of the primary on the fused PET-CT image. Metastatic disease in the right posterior acetabulum. So overall a stage 4 lung cancer. Next case. Another patient with stage 4 lung cancer. Here's the primary in the right lung. Metastatic disease in the subcarinal region, and a focus involving one of the vertebral bodies and the left proximal femur, consistent with bone metastases. Primary is seen here on the fused image. Subcarinal lymphadenopathy is seen here. Vertebral metastases and the left proximal femoral metastases. Case number 9, a patient with lung cancer with disseminated bone metastases. Here is the primary, a hypermetabolic nodule in the posterior aspect of the left lung, and we see multiple hypermetabolic foci involving the axial skeleton, the spine, ribs, pelvis, the proximal femurs, consistent with disseminated hypermetabolic bone metastases. Another patient with lung cancer and disseminated soft tissue metastases. Here is an interesting patient. Case number 11, patient with history of lung cancer with multiple foci in the left side of the chest, also in the right side of the chest, and a focus in the pelvis. They were unresectable and they were treated with chemoradiation. Look at this focus in the right side of the pelvis. It corresponds to this focus of hypermetabolism on the fused PET-CT image without any morphological abnormality on the initial CT. After chemoradiation, these foci in the chest have responded very well. The focus in the right ilium has responded well. But now after treatment, we see some sclerosis. So frequently when bone metastases heal, there is sclerosis. And on the initial exam, there may be no morphological abnormality corresponding to the focus of hypermetabolism. Case number 13, another interesting case, post chemoradiation, patient with left-sided lung cancer. Here we don't see any focal hypermetabolism, but we see mild to moderate FDG activity in a band-shaped pattern, which is seen right here. Here is how it looks like on the fused PET-CT image. We see multifocal consolidation in a geographic pattern of the radiation port, showing heterogeneous hypermetabolism, which is seen here. Now these are consistent with post-radiation changes. Typically after radiation, we want to wait for at least 3 weeks for the inflammation to subside before we do a follow-up scan to look for residual or recurrent disease. So here in this patient, our option is to now wait for some time and do a follow-up scan, which we see here. That band-shaped activity has almost completely resolved and there is no residual hypermetabolism to suggest recurrent or residual disease. Here is the appearance now of post-radiation change. You can see that multifocal consolidation has resolved and the hypermetabolism is much less intense, showing only mild activity. Case number 15, another interesting case, referred initially for evaluation of lung nodules. Here on the whole body image, we find that there is multifocal hypermetabolism involving bilateral upper lobes of the lungs. This is the appearance on the fused PET-CT image. We see multifocal consolidation, nodularity in a peribronchovascular distribution involving bilateral upper lobes, and this patient had tuberculosis. So remember, causes of infection or inflammation can also give rise to FDG avid foci on a PET scan. Case number 16, patient presented with a mediastinal mass which showed hypermetabolism, which we see here. It was initially biopsied and then resected, but there was no evidence of neoplastic disease. There was just necrosis in this region, a large lymph node with hypermetabolism, but no evidence of neoplastic disease. Next, let's move on to evaluation of patients with lymphoma using FDG PET. Here, at the time of initial staging, we want to tell them which lymph node groups are involved, one versus both sides of the diaphragm, if there is involvement of the spleen, visceral organs such as liver and lungs, and if there is any involvement of bone marrow. So here is a patient with history of lymphoma. On the whole body image, we see focal hypermetabolism involving multiple lymph node groups on both sides of the diaphragm, multiple foci on both sides of the neck, left axilla, focus in the spleen, focus in the upper abdomen, and foci in the pelvis. On the fused PET-CT images, we see supraclavicular, left axillary, hypermetabolic nodes, more left axillary hypermetabolic nodes, a focus in the spleen, a focus in the bone involving the right acetabulum, and a focus in a pelvic lymph node. This patient underwent chemotherapy, and here's a follow-up scan showing complete response to treatment with resolution of all the previously seen foci of hypermetabolism. We do see some superficial foci. These are artifact from infiltration or maybe superficial skin infection, something like that. Next case, another patient with history of lymphoma showing hypermetabolic lymphadenopathy in the neck extending into the chest, and also hypermetabolic lymphadenopathy in the abdomen. Here is how it looks like on the fused PET-CT image. The right paratracheal hypermetabolic lymphadenopathy, abdominal lymphadenopathy with involvement of a vertebral body, pelvic lymphadenopathy. Next case, the image on the left is before treatment. Here we see hypermetabolic lymphadenopathy involving multiple lymph node groups in the chest, neck, chest, and abdomen. Seen here, here, and here. And the image on the right is post chemotherapy, showing complete response to treatment. Case number 20, a patient with laryngeal squamous cell cancer. We see a focus of hypermetabolism in the larynx with no definite metastatic disease. Here is the laryngeal soft tissue thickening, which is intensely hypermetabolic on PET. Case number 21, a patient with history of head and neck cancer who has been treated with surgery and chemoradiation. This is a follow-up scan. Here we see physiologic activity in the oral cavity and a focus of mild uptake in the left submandibular region. This focus of uptake corresponds to the swollen left submandibular gland, showing FDG uptake. And here I want to emphasize the importance of looking at the whole body image, because if you're reading only on the transaxial image, you can crank up the intensity and make it look like intense hypermetabolism and call it recurrent or metastatic cancer. But when you look at the whole body image, you get a sense that the uptake is mild to moderate, sort of diffuse, involving the submandibular gland, and this is from post-radiation sialadenitis rather than recurrent cancer. Case number 22, a patient with maxillary squamous cell cancer. The primary tumor is seen here in this region, and there is a focus on the liver. Here is how the primary looks like on the transaxial fused PET-CT image. The tumor in the maxilla is eroding through the base of the orbit into the retroorbital region, and it shows focal hypermetabolism. They have a solitary liver metastasis, which is seen here on the fused PET-CT image. Case number 23. Frequently, patients with head and neck cancer present with metastatic lymphadenopathy as swelling on one side of the neck, which is biopsied, and the question is, where is the primary? Sometimes the ENT surgeons go in and biopsy multiple sites inside to find the primary, but FDG PET is also helpful in localizing the site of primary. So here this patient had left-sided neck lymphadenopathy seen here, and the primary was found in the left tonsil and adjacent focus of hypermetabolism seen here. Interestingly, this patient had left vocal cord paralysis, so the FDG uptake seen in the right vocal cord is just physiologic activity. Another patient, case number 24. Here, this patient initially was diagnosed with differentiated thyroid cancer, underwent total thyroidectomy and remnant ablation using I-131. Then they presented with rising thyroglobulin, but their I-131 scan was negative. The next step is to do a whole body FDG PET-CT scan to find dedifferentiated tumor that will take up FDG. So here on the whole body image, we find a focus in the right side of the neck and this focus of hypermetabolism corresponds to a right level 2B lymph node seen here on a fused PET-CT image. Case number 25, here we have another patient with extensive locally advanced head and neck cancer. There are also other foci which are seen here in the chest. There's diffuse increased uptake in the bone marrow, a little bit in a heterogeneous fashion. So this is their primary tumor in the left side of the neck, showing intense hypermetabolism. And there's a focus of hypermetabolism in the right side of the chest, which is seen here. The risk factors for head and neck cancer and lung cancer overlap in form of tobacco use, and frequently in patients with head and neck cancer we find incidental synchronous lung malignancies, like in this patient. Case number 26. On this whole body image, we find a focus of abnormal hypermetabolism, which is contiguous with bladder activity seen on the MIP image, and it's behind the bladder activity seen right here. This patient has history of rectal cancer. Here is the rectal thickening, which is intensely hypermetabolic. Going back to the whole body image, not very clearly seen, but this patient does have a focus of abnormal hypermetabolism seen right there in the liver. That focus of hypermetabolism corresponded to this focus on the fused PET-CT image without any morphologic abnormality on the non-contrast enhanced CT, and with small focus of mild hypermetabolism. Contrast enhanced CT showed this hypodense focus in the caudate lobe of the liver, consistent with hepatic metastasis. Case number 27, a patient with metastatic colon cancer. We see multiple foci in the liver. So the primary is seen here in the descending colon. There is a stent which is seen right here. The tumor is growing through the stent into the lumen. It is hypermetabolic. There is evidence of subcarinal and chest lymphadenopathy. Upper abdominal hypermetabolic lymphadenopathy, and evidence of liver metastases. Next case shows another patient with history with rectal cancer. We see large focus of hypermetabolism behind the urinary bladder. There is a faint focus of activity seen here in the left lung. Here is rectal thickening, which is hypermetabolic, and this focus in the lung corresponds to this hypermetabolic lung nodule consistent with metastatic disease. Case number 29, a young female with history of colon cancer that has been resected, and they presented with rising CEA. We see physiologic activity in the thymus, physiologic breast activity which is symmetric, and a focus in the liver consistent with metastatic disease. This focus is better seen here as segment 6 focus of hypermetabolism consistent with hepatic metastases. Next case, another patient with history of rectal cancer, which is seen right here behind the urinary bladder, and an incidental focus of hypermetabolism in the chest. Rectal thickening, which is hypermetabolic, and the focus in the chest corresponds to mural thickening involving the esophagus. This was evaluated by upper GI endoscopy and biopsied. This was a synchronous squamous cell esophageal cancer. Case number 31. Patient with metastatic gastric cancer. Here's the primary. The primary is better seen here. Focus of hypermetabolism and mural thickening at GE junction. Multiple foci in the liver consistent with metastatic disease. there is hypermetabolic lymphadenopathy in the chest, and there are multiple hypermetabolic metastatic lung nodules. These are post-therapy changes from the same patient that we saw before. So let me go back one slide. Gastric cancer with metastatic disease in the liver and the lungs. Post-treatment, there are several foci here in the upper abdomen, foci in the chest and the left supraclavicular region. Hypermetabolic subcarinal lymphadenopathy, and a new left hypermetabolic supraclavicular lymph node consistent with progressive metastatic disease.